Welcome back to Mostly True Psychiatry with Dr. Mellon. As always, please share, leave comments down below. I will read so I can see what you want me to do in the future. And also, I'm not your doctor. Treat this like a textbook. I'm not giving you advice, just telling you stuff. Alright, so this is going to be very specific. This is going to be about the side effects of SSRIs used to treat MDD. So let's get into it. So SSRIs, FDA drugs that are approved for this are everything but fluvoxamine. Apparently didn't work. Everybody else got to join the club. So there you go. Any other one is fine. So let's talk about general things on side effects for SSRIs as a group. Here's a picture just to kind of think about something. You'll notice super lit up on the side, right? Sexual dysfunction. All SSRIs, they all cause problems. Paroxetine especially, which means maybe paroxetine's a good drug for somebody who has an IQ of 45 and you're trying to keep them in school at age 19 and they're trying to dry hump people and it's not appropriate. You can say they're anxious and give them paroxetine to try to stop them from doing that. And you're going to see citalopram is a big red box for QTC. We'll talk about that. And then fluoxetine is quote-unquote activating, so it causes problems with insomnia, agitation, that kind of stuff. And then paroxetine has kind of anticholinergic, orthostatic hypotension, weight gain problems, so it's a weird drug. You can tell by that. Activating and sedating. So theoretically, we love terms that are weird and don't make sense for anybody else. So increased energy, activating. It's supposed to be fluoxetine, sertraline. So a patient who doesn't move around is very sleepy, very tired, very lazy, doesn't want to do anything, feels real bad about themselves. That's probably a decent drug choice, right? You're trying to get them to feel like they have more energy and not have to give them meth. I like to just always make sure everybody knows. Any pill you put in your mouth will cause headache, nausea, vomiting, diarrhea, constipation, abdominal bloating. So I could give you a rock or a sugar pill and you're still going to say that at some rate. So, just do good practices. Go low, go slow, warn them. I like to give, if people are going to complain about side effects, maybe give it at night and they sleep through it. So it's kind of like, does a tree make a sound if it falls in the woods and no one's there to hear it? Physics answers yes. Sound is not special to us. It does make sound waves. But anyways, sexual dysfunction will do as its own special thing at some point in time. It's all of them. Paroxetine's terrible. SIADH, so hyponatremia, low sodium is a thing, right? It's listed for every SSRI. Depending on the studies and when you look at it, they're going to use different cutoffs of 135 or 130. I'm kind of stringent when I look at the research. 135 happens a lot for a lot of reasons, so I'm going to use 130. Why do you care about SIADH? If you have very low sodium and you go, and I'll give you lots of sodium back, you can suck their brain through their foramen magnum and cause brain damage, which is not cool. So low sodium is a real thing if it happens. Recent studies don't really support that SSRIs do this. So if you basically look at the 130 as the cutoff, it happens between, this number is so small, what the heck is it? 0.6% to 0.2 or to 2.5%, which also is a large confidence interval, which tells you how it's, if you have something that is a very low incidence rate, it takes a very big population to actually know the answer, which that's a big range, so we probably don't know the answer. May or may not be a significant finding. Act like it is. Don't get yourself in trouble. And then they've done like geriatric studies. I never looked into it. I don't know the number of patients or people that went in study. Maybe it was 10. I don't know. And they said, well, the odds ratio of getting hyponatremia went from 2.5 to 11 with an SSRI. So that's true then. We probably don't want to give them to any old people. I don't know. Which we do. So I don't know. Whatever. Let's see. We're not going to do any controversies. Withdrawal effects. So stopping an SSRI does not feel good. What does not feel good mean? Flu-like symptoms. I wrote it twice for reasons. Headache, nausea, vomiting, dizzy, muscle pains, which is flu-like symptoms. Abnormal sensation, asthenia, which is electrical shocks, is also asthenia. So I should clean this up at some point. So we call it a discontinuation syndrome in psychiatry, or that's how we're taught to do it. I will just add as the controversy here, I won't go into the specific, but you should not use terms that other fields don't use. Don't make up words that is special to you in neurology and general medicine and everybody else doesn't use. You have dependency and withdrawals. If you stop taking the drug and it feels real bad, you have a physiological effect like flu-like symptoms because you were mainlining heroin over and over and over and over for weeks on end, then you stopped all of a sudden, then you had flu-like symptoms and abdominal pain. We don't say, oh, look, you had discontinuation syndrome. Like, no, you had withdrawals. You had physiological symptoms. So yeah, I just call it withdrawal effects. All right, so there's enough of that. I'm going to have to do cytochrome P450 system in its own lecture because I started that this morning and it became a huge, huge rat hole. So let's just go over some of the actual individual drugs now. So they all do those kind of generic things we said. Oh, wait, we talked about weight gain. I didn't say anything about that. So weight gain. So we like to do this thing where we say some of them cause more weight gain than others, like Paroxetine and Sertraline are worse than these other drugs, even though Paroxetine has more anticholinergic type stuff, which is why we say quetiapine causes so much weight gain and olanzapines. I don't know. When they tried to do a study and they compared it to placebo, people gained more weight with the placebo. So it's in the margin of error, so they probably don't cause weight gain. Maybe you just didn't eat when you were depressed, right? Some people don't eat a lot when they're depressed. That doesn't mean you gained weight because of the drug. That means you fit one of the diagnostic criteria of depression and didn't want to eat, and then you felt better and you gained weight. All right, so I guess that's just kind of how it works. All right, let's go to the individual drugs now. So sertraline, you're supposed to know that it causes tummy pain. If I give you 200 milligrams, you will have abdominal pain and feel horrible. The theory is it affects a specific serotonin neurotransmitter, the 5-HT3, which I will not try to make myself look like an idiot. I will look at it because I think it's like the chemotactic something, vomit center. Chemotactic trigger zone. There we go. Vomit center, right? That's easier to remember. So this shouldn't be theory because ondansetron is an anti-nausea medication that blocks 5-HT3. So if sertraline is hitting a 5-HTC3 and causing nausea, you should be able to give it ondansetron, like 200 milligrams of sertraline plus that. It shouldn't happen. Probably look that up. If that research hasn't been done, there's an easy way for you to crank a paper. It's probably been done, but let's see. So that's really the big thing for it. It can displace warfarin. Just start low, go slow. You can avoid the nausea, abdominal pain. Citalopram, it has a biggie. Qtc Prolongation. What is Qtc Prolongation? For men, it means that adult men, it's 450 milliseconds or longer on an EKG. The QT corrected interval is 450 or longer. For women, it's 470. That's using basically the Bazette corrected version, which means your heart rate is like 60 to 100. If it's outside of that, you have to correct it more, and they have more corrections for them. So why is that a problem? Because if QTC is very long, you get torsades de pointes. Why is that a problem? Because that equals death. It's a heart attack. And this drug, when they tested it, they said 8.5 milliseconds. What's the 90% confidence interval for QTC prolongation? 6 to 10. Cool. What if we give you 40 milligrams? It's 11 to 14. Cool. What about citalopram at 60 milligrams? 16 to 20. Yeah, let's never prescribe it at that dose again. And we stopped. So 40 milligrams is the highest dose that you can prescribe. Or should prescribe, and never give this to somebody who has heart problems. And it just occurred to me, this is probably the most dangerous SSRI ever created, because if this is a linear relationship, somebody should be able to eat a bottle and die. Probably makes it more dangerous than a TCA at that point, right? I don't know. Food for thought. So, escitalopram, its major side effect is, doesn't taste good. You can give 5 milligrams of escitalopram to a 105-year-old man who had a heart attack, fell off his walker, smashed his head on a table, ended up with a brain hemorrhage. He's been in a hospital for a month and he's super depressed, and you go, oh, here's 5 milligrams of escitalopram. So it's your go-to when everything is scary. It has no side effects. It doesn't interact with drugs. It does nothing but help depression and anxiety. Fluoxetine, it's a big weird molecule. It can worsen anxiety because it's activating. It can cause problems with insomnia because it's activating. It has drug-drug interactions because it's a weird old molecule. We'll talk about this later. Bupropion, fluoxetine, paroxetine, they actually all have CYP2D6 strong inhibitors. Fluoxetine's the only one we talk about. I don't know. I'll go into this later at a different time. Weird evidence that it's a bad option for people who have breast cancer for tamoxifen. It's bad evidence. There's evidence. Probably don't do it. You don't want to get sued. And that leaves us with paroxetine. So the one thing to know is do not give this to a woman of childbearing age. It's teratogenic, cardiac malformation, the worst choice for SSRI in pregnancy. It has the most sexual side effects, like I talked about earlier. It's anticholinergic at higher doses, and it gives the worst withdrawal effects because it has a super short, half-life compared to the other ones, not even a day. So, so it's not good for young kids because they're going to crank through it and have withdrawals. It's not good for old people. It's anticholinergic. So, special place is basically sexual dysfunction. Alrighty, folks, that's all the time I've got for this video. So again, smash that like button, share, comment. But seriously, on the comment though, like, tell me what you want. Tell me if you have anything you want me to think about, read, disagree with stuff. It's all cool. Don't worry. It's mostly true psychiatry.